We're going to see the management of ventricular tachycardias with and without pulse. So ventricular tachycardia without pulse, that is no pulse, negative pulse. This would be treated as the same as ventricular fibrillation, and we already talked about this. We will begin first with the VCL, so the patient is lying on the floor, non-responsive. We begin the 5 cycles of 30 compressions to breath, and when the monitor arrives, we will see a ventricular tachycardia without pulse. So we will see a narrow complex QRS, for example, something like this, a QRS like this, and just the T wave. We have no P because here the pacemaker is the ventricle, so we have ventricular tachycardia. More than 3 beats is sustained ventricular tachycardia, and so we know that the patient has ventricular tachycardia without pulse, and this is a shockable rhythm, so we will give a shock. Next, we will resume immediately CPR, so 5 cycles of 30 compressions and to breath. We will check again the rate after the 5 cycles, so that is around 2 minutes. Then here, if we continue to see ventricular tachycardia with no pulse, ventricular tachycardia, we will give again another shock and resume CPR. But here we can also infuse epinephrine. In order to make that the next shock, in case that it be necessary, increases the chance that the patient makes it. So here we check again, the patient continues with ventricular tachycardia, so again shock and resume CPR immediately, but now we would give amiodarone. And remember, we're alternating between epinephrine and amiodarone. We can give epinephrine up to 3 times. The dose is 1 milligram bolus. The doses of amiodarone is, the first one is 300 milligrams, and the subsequent doses are 150 milligrams. Alright, and push doses. Unless the ventricular tachycardia now converts to asystolia or something like that, we then continue with that algorithm that we already saw it, and it's quite the same thing. If we the last thing that we did was epinephrine, now we will give amiodarone, but without the shocks. And remember the quality of the compressions, etc. Alright, now this is ventricular tachycardia with no pulse. Now ventricular tachycardia with pulse, so here the pulse is present. Now if the pulse is present, the next step is the patient is stable, hemodynamically stable or not. With hemodynamically stable, I mean, for example, the signs of hypotension or hypoperfusion of the organs, altered mental status or chest pain, but lightheadedness and palpitations are not signs of hypotension, so just this one. So if the patient has this, then that is, if the patient has any one of these, the patient is not stable. So if the patient is not stable, so non-stable, well, not stable, then we need to cardiovert this patient, so we do cardioversion. But this cardioversion is synchronized cardioversion. Here the shocks were unsynchronized cardioversion, the same thing as saying defibrillator. But here we are giving a synchronized cardioversion because the patient has pulse, and we need to synchronize this shock with the QRS, because if we do the shock on the T wave or the ST segment, we can convert the ventricular tachycardia to ventricular fibrillation or asystole. So here we are giving a synchronized cardioversion. Next, if the patient has pulse and is hemodynamically stable, then we have 2 options. Either this patient has well, here I say ventricular tachycardia, but that is a wide, complex ventricular tachycardia, because we don't know if it's ventricular or atrial tachycardia with aberrancy. So one thing that we can do is give adenosine, and if it resolves, then it was a atrial tachycardia like rentral, tachycardia or supraventricular tachycardia, something like that. But if it does not resolve, yes, we can think, for example, other atrial tachycardia or atrial dysrhythmia with aberrancy. That could be, for example, atrial fibrillation, or we can think on the ventricular tachycardia. The key here is that atrial fibrillation is irregular and ventricular tachycardia is regular. So then we will give drugs. These drugs include amiodarone or sotalol or procainamide. If this does not work, then we will try lidocaine, and if this does not work in cardioversion, here the dose of amiodarone is 150 milligrams per minute. This is the push dose, and the infusion or the maintaining dose is like 1 milligram per minute. Procainamide is between 20 and 50 milligrams per minute of push dose, and the infusion or maintenance dose of 1 to 4 milligrams per minute. And sotalol is like 1 to 0.5 milligrams per kilogram of body mass in 5 minutes, and here 100 milligrams in 10 minutes. 10 minutes. These are the doses. If this does not work, we try lidocaine. On ventricular tachycardia, we can have a monomorphic or a polymorphic. If it is polymorphic, it could be dorsal points, and here also it would be an irregular one. So here we would give magnesium. We can also give isoproterenol because it will narrows the Krebs complex, and magnesium is given as sulfate of magnesium. And if this does not work, lidocaine. If this does not work, cardioversion. So if the patient has a tachycardia that is unstable, we will shock the patient with a synchronized cardioversion, meaning that it has ventricular, it has pulse and is hemodynamically unstable. So for a monomorphic one, so if we on the monitor we see that it is monomorphic, and we are about to calibrate the patient, we will give first one shock of 100 joules. The next, if the patient requires another, the next one is of 200 joules, the next one of 300 joules, and the subsequent of 360 joules. If the patient has the polymorphic one, it depends on if we are using a monophasic or biphasic. It usually is 360, depending, certainly on what it is. If it is the polymorphic tachycardia with polymorphic tachycardia that is dorsal the point that is not responding to magnesium, isoproterenol, then we calibrate to 360. But if the patient has the hemodynamically instability with a polymorphic tachycardia, then we usually give like 100 to 200 joules or any other that the monitor is suggesting. So that's the management. The first step is we have a pulse or don't pulse. If we don't have the pulse, is like ventricular fibrillation and is the shocks, epinephrine, amiodarone. If the patient has pulse, then we see if it's hemodynamically stable or unstable. If it is unstable, and monomorphic 100, 200, 300, and 360 for the subsequent. If it is polymorphic, we should think in dorsal de Pont, so we need to give magnesium. If it doesn't work, it's a proterenol. If it doesn't work, lidocaine. If it doesn't work, cardioversion. And if the patient has a stable wide complex tachycardia that is monomorphic, we treat it with amiodarone, sotalol, or procainamide. If this does not work, lidocaine. And whenever we are treating a wide complex tachycardia, we are not sure if it is ventricular or atrial tachycardia with aberrancy. So sometimes we decide to begin with adenosine in order to see if it reverts or not, because if it revert, it was the atria. But in other cases, we can also begin just with giving amiodarone, because amiodarone is a very powerful antiarrhythmic drug, can treat atrial and ventricular tachycardia as well. So whatever one you prefer to use, you can begin with adenosine or you can begin with amiodarone. And amiodarone, the dosage is 150 milligrams in 10 minutes for the ventricular tachycardia that has pulse. When we are giving amiodarone, alternating with epinephrine, the first one is 300, the second and third one are 150 milligrams. And for epinephrine, always is 1 milligram.